Just we'll give it half minute so to have stabilized once. طيب بسم الله الرحمن الرحيم والحمد لله والصلاة والسلام على رسول الله. Dear colleague, thank you very much of attending this educational event that's organized by your beloved society, the Saudi Society of Nephrology and Transplantations. And as our commitment of continuing the medical education, so this time will touch on important topics that facing many nephrologists, and they have difficulty in managing it and in diagnosing it. And we have selected, as usual, one of the top-notch speakers. As well, our colleague will be the moderating of this session, Dr. Talal Al-Fadl. He will moderate the session. Before I hand over the mic to my colleague, I would like to thank Sobi for supporting and sponsoring this event. Without their continuous support, we cannot have this medical educations and these events. Also, I would like to announce for our upcoming congresses. We have two upcoming congress symposium actually. One on 15 and 16 of May, which is about the glomerulonephritis. It's complete 2 days talking about from A to Z about all what you need to know in glomerulonephritis, and it will be here in Riyadh. Most likely gonna be in Crown Plaza Hotel, and the second event will be in November, again in the mid of November, which is about the advanced BD form. So please mark your calendar for those upcoming big events for the society. Without much of delay, I will hand over the mics to my colleague, Dr. Talal Fadl, to introduce himself and to introduce the speakers. Talal, the mic is yours.
So thank you, Prof. Khalid, and thank you to the Saudi Society of Nephrology for giving us this opportunity to touch on a very important disease. I would like to introduce our speaker. So for those who don't know, Dr. Fernando, he's Dr. Fernando Caravaca Fontan. He's from Spain and working right now at the University Hospital as an attending staff and also at the clinical investigator in the Research Institute Hospital. He's actually a clinical coordinator at the Spanish group of the study for glomerular diseases, the GLOSEN group. And for those who don't know, the GLOSEN are like in glomerular diseases, they're like the Spanish national football team. So they are very well known and recognized, and they're doing a brilliant job in the field of glomerulonephritis. So, and he's also a board member of the European Era Young Nephrologist Platform. Without further ado, Dr. Fernando will be talking about a disease-modifying approach to diffuse C3 dysregulation and C3 glomerulopathy and primary immune complex MPGN. So the mic is yours, Dr. Fernando.
Yeah, so good afternoon, everybody, and well, thank you so much for the kind invitation. It's my real pleasure, my honor to participate in this very interesting webinar. And well, I will do sort of a review or a summary of this disease, and perhaps afterwards we will be able to have a very interesting discussion. So yeah, let's get into business. Well, over the last decade, complement activation and dysregulation of complement has been involved in a wide variety of systemic and kidney diseases. And some examples of this include, of course, C3 glomerulopathy, but also other glomerular diseases such as IgA nephropathy, membranous nephropathy, ANCA-associated vasculitis, and of course, atypical hemolytic uremic syndrome. As you know, the complement system is composed by a set of plasma molecules that interact in different biochemical cascades, and there are three main activation pathways, the so-called classical, the lectin, and the alternative complement pathway. And this one, the alternative complement pathway, is constitutively active at a low level, so it's therefore needed some regulators to avoid self-damage to self-structure. So in this regard, the complement system should be a tightly regulated, and depending on the balance between these different regulators and activators and intensity of a certain triggering condition, this may lead to an overactivation of complement, leading to damage. And the two main complement-mediated diseases are atypical hemolytic uremic syndrome and C3 glomerulopathy. And the main difference between the two is that while in atypical hemolytic uremic syndrome, the main complement dysregulation occurs at the endothelial level, leading to this systemic complement activation. In C3 glomerulopathy, this complement dysregulation occurs in plasma, leading to a massive deposition of these C3 molecules in the glomeruli, and also in the glomerular microenvironment, and this leads to a progressive inflammation and damage. So, C3 glomerulopathy is defined by this disease that occurs in the setting of this complement dysregulation. And as I mentioned, there are these progressive deposition of these C3 molecules that are represented here in this slide as these blue dots. And depending on the location of deposits in electron microscopy, two subtypes are distinguished: the so-called C3 glomerulonephritis, in which deposits are mainly found in the mesangium and the subendothelial space, and the dense deposit disease, in which we will find deposits all along the GBM. So the current consensus definition relies on the presence of either exclusive C3 deposits on immunofluorescence staining or predominant C3 deposits defined as at least 2 orders of magnitude greater than the rest of immune reactants. However, in recent years, it has been shown that there may be cases that do not actually fulfill this dominant deposition. So these are mainly called as immune complex mediated MPGN. However, no secondary causes are found, and these cases labeled as primary IC-MPGN has been found to be also there may be underlying complement dysregulation, either due to genetic factors or acquired factors. And therefore, these cases of primary IC-MPGN should be considered as part of the same disease spectrum as C3G, and therefore there is rationale to be treated in a similar fashion. So the pathological process, again, that leads to this disease is this complement activation and dysregulation, this progressive deposition of these C3 molecules that will lead to inflammation and progressive damage. And even though the underlying pathogenesis is still not yet completely understood, based on different retrospective and observational studies, it has been found that this complement dysregulation may occur in the setting of complement genetic variants, and this may be responsible for about 70 to 20% of the cases. And these are genetic variants that lead to loss of function of these regulators, such as complement factor H, factor I, or gain of function variants in other genes, such as those that lead to a complement factor B, C3, and in a more rare occasions, there may be in the setting of complement factor H related proteins. However, in the majority of these cases, even though there are also challenges in defining and determining these acquired factors, these may be in the setting of autoantibodies. And the main autoantibodies involved are the so-called nephritic factors, which have the ability to sort of stabilize the C3 convertases, leading to a massive activation of complement in plasma. Other autoantibodies are the so-called anti-factor H antibodies or anti-factor B. And of course, if we diagnose a C3G in the setting in older patients, we should also rule out the possibility of an underlying monoclonal glomerulopathy. And even though the mechanism of complement dysregulation in this setting is not well understood, it has been suggested that these monoclonal proteins can interfere with the normal regulation of complement, leading to this hyperactivation. Now, if we if we talk about the clinical presentation, this clinical presentation may be highly variable. There may be cases that are diagnosed asymptomatically, so patients just have some degree of proteinuria, a little degree of microscopic hematuria, whereas others have a more overt clinical presentation with a nephrotic syndrome or even nephritic syndrome or rapidly progressive kidney failure. And even though the underlying pathogenesis is complement dysregulation, low serum C3 levels may be found only in about 50% of the cases. And this is because complement dysregulation may occur not only in plasma, but just in the glomerular microenvironment. So that means that if a patient has normal serum C3 level, this does not rule out the possibility of an underlying C3 glomerulopathy. Now, the natural history and prognosis of the disease is not well defined in the literature, and this is because this disease was recognized as an independent entity in the last decade. So therefore, this natural history is not well defined, and there is high heterogeneity, and also there are important retrospective biases in the previous cohorts that have been published. However, the disease usually follows a relapsing remitting course. So this means that there may be cases in which the disease are more active, whereas in others, the disease is sort of more stable. However, the current prognosis of the disease is not good, with up to 30 to 50% of patients eventually progressing to kidney failure within 5 to 10 years from diagnosis, further requiring dialysis or transplantation. Now, in terms of the main determinants of outcomes, this is an editorial in which we summarize the main clinical and histologic covariates that were associated with this risk of developing kidney failure. And it is not surprising that, as with other glomerular diseases, the kidney function at the time of diagnosis, measured either with the serum creatinine or EGFR, and also the degree of proteinuria, and also the changes, the degree of proteinuria at baseline, but also the changes over time, were the main determinants of developing kidney failure. And in terms of the histologic parameters, the degree of chronicity, particularly the degree of glomerulosclerosis, interstitial fibrosis, and tubular atrophy, were the main determinants of outcomes. The main problem when evaluating the potential effectiveness of new drugs in this disease is that kidney failure is a late event in the progression of the disease. And therefore, we need surrogate endpoints to predict clinically relevant events and to investigate the potential effectiveness of these new therapies. And the current consensus suggests that the main surrogate markers of outcomes are EGFR, so the changes of EGFR over time, the changes of proteinuria, and also the changes in histology. These are sort of the main surrogate markers that have been approved or are evidence for other glomerular diseases. So what is the evidence that supports the use of proteinuria as a surrogate marker for C3 glomerulopathy and IC-MPGN? So among others, there's this study that we performed in Spain, in which we retrospectively collected a cohort of patients, 149 patients with C3 glomerulopathy. The majority of them were the C3G. However, we also included patients with primary IC-MPGN, which were only 34% of the cases. And we retrospectively collected in a longitudinal fashion the changes of EGFR and proteinuria over time. And our hypothesis was that an early change in proteinuria could help predict the prognosis of the disease. And this information could be relevant to extrapolate for evaluation of the effectiveness of the drugs that were under investigation in clinical trials. So we basically use a joint multivariable analysis, which combine a linear mixed effects model together with a Cox regression analysis. And after adjusting for several factors, we found that the longitudinal changes in proteinuria were strongly associated with the risk of developing kidney failure, and that patients that showed at least 50% proteinuria reduction over time had a significantly better kidney survival over time. In addition, we found that patients that had a time average proteinuria under 1 gram per day had a significant better kidney survival, which suggests that perhaps this target of proteinuria under 1 gram per day and ideally under 0.5 gram per day would be associated with improved kidney outcomes, and therefore this should be a target for our clinical practice. Similar results have been found in other collaborative cohorts, either from Italian registry or collaborative studies that were combining other different cohorts across Europe, and further suggest that this target of proteinuria under 1 gram per day should be something that we should try to achieve in clinical practice. Now, in terms of the eGFR, as we know, patients progress through declining levels of eGFR before reaching kidney failure, and as such, clinically significant treatment effects on the loss of kidney function as measured by eGFR would be expected to predict treatment effects on progression to kidney failure. And even though in the particular case of C3G, there are no specific evidence, there are analysis of outcomes from UK rare kidney disease registry, the so-called RADAR registry. They found that for patient, the kidney failure has a ratio for -6 millimeter per minute per year compared to stable eGFR was 1.61, which means that patients that showed this eGFR decline had a worse kidney survival compared to having a stable eGFR. However, we should also take into account that patients may show different patterns of progression. So there may be cases that have a more rapid eGFR slope over time, whereas others have a more slowly progressive decline. So we should also take into account this in an individual clinical practice. Now, in terms of the histology, as we know, the kidney biopsy will be fundamental for establishing the diagnosis, but the kidney biopsy will also provide us with very relevant information from a prognostic standpoint. And this is a study that was performed at Columbia University in the United States, and they proposed a histopathologic index to evaluate different activity and chronicity parameters. There were different histologic features that were evaluated in each kidney biopsy. Each of them were scored as 0 to 3, except for atherosclerosis that were scored as 0 to 1. And based on this, they calculated a total activity score and a total chronicity score. And so they found that in multivariable analysis that both the total activity score and the chronicity score were independent predictors of outcomes. And well, in Spain, as part of another sub-analysis that we performed in our nationwide study, we aim to validate the reproducibility of this histopathologic index and to analyze the prognostic value. And so we analyzed different kidney biopsies using this histopathologic index. And in contrast with the American study, we found that the main determinant of outcomes was the degree of chronicity, which in this case was, we used different thresholds based on the median values. And we found that patients that had higher values of chronicity had worse kidney survival compared to those that had lower values. Whereas for activity score, there were no significant differences. So again, this highlights the importance of the degree of chronicity, which actually is telling us that perhaps some degree of the damage may be irreversible. And finally, regarding the histologic parameters, we know that the disease occurs in the setting of the deposition of C3 molecule and degradation fragments in the glomeruli. And so if a new drug is able to sort of halt or reduce or even make disappear the position of C3 in a kidney biopsy, this will be telling us that the drug is actually targeting the underlying pathogenesis and is blocking the underlying pathogenesis, and this will be associated with improved outcomes. Now, this disease is particularly challenging in other clinical scenario, which is the kidney transplantation, because patients may suffer disease recurrence in more than 50% of the cases, and up to 50% of patients may have a graft failure due to recurrent disease in the allograft. So again, the disease does not end up with kidney failure, with a dialysis or even transplantation, but these patients may suffer this recurrence risk, and this will be associated with very worse outcomes overall. And the truth is that at present, uncertainties outweigh established evidence, and there are still important unmet needs and research gaps in this particular case of recurrent risk, recurrent disease in the allograft, particularly from a pathogenesis standpoint. So there are no good biomarkers that define risk factors for developing this recurrent risk. Also, in terms of how to better an early diagnose these cases and monitoring these cases, and of course, in terms of the treatment and improving the prognosis. However, as we will see later in the presentation, new evidences and new treatment strategies have become available, and these perhaps will help us improve the prognosis of the disease. So again, talking on the recurrence risk in the kidney transplantation, older studies identify several predictors of recurrence, including living donation, other triggers for recurrence, including infections, ischemia, reperfusion, younger age at kidney transplantation, higher proteinuria, and low serum C3 levels. However, several studies were from periods when C3G was not even recognized as an independent entity, and therefore there are still important knowledge gaps in this case. This is an old study that came from the Mayo Clinic in the US, and they included 21 patients with C3 glomerulonephritis, and up to 67% developed recurrent disease in the allograft, and 50% of them suffer graft loss. And one of the important points here is that a significant number of patients were treated with some conventional immunosuppression, and these treatments were not effective at all. This is another study, again from the Columbia University. They found a higher rate of recurrence, up to 89% of the cases, and as early as 13 days after kidney transplantation. And perhaps this greater number of the recurrence rates was because a significant number of them were detected via protocol biopsies. And perhaps this would be the ideal way to early diagnose these cases and early treat these patients before they start developing kidney injury and graft lesions in the setting of this early recurrence. In Spain, we also performed a retrospective analysis, which tried to evaluate patients that had this membranoproliferative glomerulonephritis pattern in kidney transplantation, and we differentiated those that had this immune complex mediated MPGN and complement mediated MPGN. So we included in this retrospective analysis 220 patients, and we analyzed the determinants of kidney failure, the recurrence risk and the risk factors, and also the determinants of non-remission. So we evaluated retrospectively what were the underlying etiologies of this MPGN pattern. We found cases that currently are, of course, less frequent: hepatitis B, other autoimmune disorders that were underlying this membranoproliferative pattern. However, in a large majority of them, we were not able to identify an underlying cause, and therefore these cases were labeled as idiopathic. And we identified cases that were complement mediated. So these were actually C3G cases, and these were 21 cases. So as you can see, the greatest risk of developing recurrence in the allograft was related to this underlying mechanism of action. So those that were complement mediated had higher rates of recurrence, and particularly those with this proteinuria, even though these numbers were rather small. So these were in a multivariable analysis. We found that complement-mediated MPGN had higher risk of recurrence, and after recurrence, the risk of developing a kidney failure was particularly greater in patients that had an early recurrence, those that had a lower eGFR at the time of recurrence, and also lower serum albumin as a marker of a higher or a more aggressive phenotype. And despite all these advances, actually significant knowledge gap remain in this particular field, and therefore it will be necessary more studies that further characterize natural history. Of course, we need reliable predictors of recurrence, and the importance of these surrogate markers to evaluate the outcomes and the risk of reaching graft failure after a recurrence. Now, moving on to the treatment guidelines and moving on to the treatment, if we take a look at the KDIGO guidelines for the management of glomerular diseases, this particular chapter on C3 glomerulopathy and MPGN, well, this is from 2021, so guidelines are a little bit outdated, and we already know that a lot of water has flown under the bridge and things have significantly changed. But these 2021 outdated guidelines suggested that no optimal treatment had been established, and so they suggested for patients that had proteinuria about 1 gram per day to start with some supportive care. For those that had moderate to severe disease with a more persistent proteinuria together with declining eGFR and hematuria, to start with immunosuppression, including a combination of corticosteroids plus MMF, or even considering anti-C5 therapy with eculizumab, particularly with those with rapidly recursive forms, even though at that time guidelines recommended patients to be enrolled in clinical trials. So what is the evidence behind this recommendation on the use of MMF? So again, in Spain, we perform a retrospective analysis which analyzed what was the kidney survival and the prognosis of patients with C3 glomerulopathy. And we found that patients that had been treated with this combination of immunosuppression had a significantly better kidney survival compared to other immunosuppressants. However, and here in this right-hand side of the slide, the clinical experience that have been published from other cohorts in other countries have shown that roughly we may say that patients that receive this type of immunosuppression perhaps may show a lower rate of clinical response. And so we may say that patients treated with immunosuppression may roughly show a response in about 30 to 40% of the cases, whereas up to 40% of cases may show no response and even progress to kidney failure. And these tell us that there are important unmet needs in the management. And of course, we know from clinical practice that actually by using this type of immunosuppression, we are not targeting the underlying pathogenesis, so perhaps we are just dealing with inflammation in the glomeruli, and this may justify that perhaps patients just show a transient improvement in kidney function or even in proteinuria, but in the setting of this reduced local inflammation, but without targeting the underlying pathogenesis. So again, important unmet needs if we pull all the experience together. Now, in terms of using eculizumab, well, the positive result of eculizumab in atypical hemolytic uremic syndrome led to these initial experiences with the use of eculizumab in C3G. However, the results were highly disappointed. And this is because actually, if we use eculizumab, we are not targeting the underlying pathogenesis, which again in C3 glomerulopathy occurs at the level of C3, whereas with eculizumab, we are targeting downstream, we are targeting at the level of C5. So this is the reason why the results were not as effective as in atypical hemolytic uremic syndrome. And therefore, again, based on observational studies, current recommendations are for patients that have a rapidly progressive form of the disease with presenting forms of the disease. And this is perhaps just because of the important anti-inflammatory effects of eculizumab. But perhaps if for patients with a rapidly progressive form of the disease, we use C3 target therapy, perhaps we will be effectively targeting the pathogenesis and the inflammation in a similar or even more effective fashion. So yeah, again, this is the recommendations and the rationale for these recommendations. Fortunately, over the last year, several new drugs have been developed. So we have an factor B inhibitor, which is called Iptacopan, factor D inhibitor, Danicopan, C3 inhibitor, which is Pegcetacoplan, and C5a receptor antagonist, which is Avacopan. And these drugs were tested in C3 glomerulopathy. And well, to make a long story short, only 2 drugs showed positive results for C3 glomerulopathy in this case. And these are the drugs that I will be discussing in the next slides. So first, talking on Iptacopan, this is an oral agent that targets factor B, and the pivotal trial that analyzed the effectiveness of these drugs in C3 glomerulopathy was the APPEAR-C3G, which included 2 phases: a double-blind phase in which patients receive Iptacopan's 200 milligrams twice a day versus placebo, and an open-label phase in which all patients received the drug in an open-label phase during 1 year. The main objective was the evaluation of Iptacopan on proteinuria at 12 months, and secondary endpoints, including composite kidney out endpoint, including the eGFR and proteinuria, and of course, the safety and tolerability. These are the baseline characteristics. This trial only included adult patients and only included C3 glomerulopathy patients, so they did not include these forms of primary IC-MPGN. And as you can see here, there were 38 patients that were randomized to receive Iptacopan and 36 to placebo. And well, patients that initially received Iptacopan had a little subtle difference, higher baseline proteinuria and a slightly lower eGFR. But apart from that, the results were, the patient characteristics were fairly similar. So the results show a proteinuria reduction of 35% at 6 months, so this initial double-blind phase. And after switching from placebo to Iptacopan, patients also show a reduction in proteinuria that were at about 31%. So we can say that patients that receive Iptacopan may show about 30 to 35% proteinuria reduction. Also, there was a stabilization of eGFR, and also the trial compared what was the changes in eGFR prior to randomization and after being randomized in the trial. And as you can see here, patients were showing a significantly eGFR decline at about -7 to -10 millimeter per minute per year. And these sort of stabilized, but it is important to note that actually they stabilized both in the placebo arm and also in the treatment arm. So that actually is telling that perhaps neither the placebo arm were correctly treated at the time of being diagnosed. So this is something that perhaps is also controversial from this study. Now, moving on to the Pegcetacoplan. Well, first of all, Pegcetacoplan is a broader complement blocker. So this drug actually targets the C3 convertase, but not only the alternative complement pathway, but the C3 convertase that come from the lectin pathway and the classical pathway. So this way, this is sort of a broader umbrella that blocks the complement, and it also blocks the amplification loop, and therefore it prevents the generation of these downstream effectors and preventing this inflammation and the progressive kidney injury. Now, the pivotal trial that evaluated the use of Pegcetacoplan in C3G and IC-MPGN was the Valiant study. This was recently published in New England Journal of Medicine. And it is important to note that compared to Iptacopan, actually this trial evaluated the drug not only in adult patients, but also in adolescents, aged above 12 years of age, not only in native kidneys, but also in recurrent disease in the allograft. And again, not only included patients with C3G, but also patients with primary IC-MPGN. The design of the study was fairly similar. So patients had in a initial double-blind phase, patient received Pegcetacoplan plus a standard of care compared to placebo. This was during 6 months, and afterwards, all patients received the drug during another 6 months. So again, the endpoints were similar with changes in proteinuria, changes in eGFR, and also changes in histology at 6 months. These are the baseline characteristics. As you can see, the number of patients randomized were larger. So there were 63 patients in the Pegcetacoplan arm compared to 61 in the placebo arm. And patients had significant proteinuria at the time of randomization, and also significant, so the eGFR was fairly well preserved. And as you can see here, this is the primary endpoint. The drug show a highly statistically and clinically significant proteinuria reduction, up to 68%. As you remember, Iptacopan only show a 35%. So this is showing us that the drug is perhaps more effective. And importantly, the results were consistent across all the different subtypes. So not only in adults, but also in adolescents, not only in C3G, but also in IC-MPGN, and in both native kidney disease and kidney transplantation. So the results were highly meaningful from a clinical perspective in terms of this proteinuria reduction. In addition, a greater number of patients that received Pegcetacoplan achieved this target proteinuria reduction of under 1 gram per gram. And this was very early in the course of follow-up. So as you recall, so these results were in just 6 months. So this is a great result, and actually is telling us about the effectiveness of the drug and the rapid effect of the drug in terms of targeting these proteinuria levels. Also, there was a trend towards a stabilization of eGFR compared to placebo. And importantly, in the patients that received Pegcetacoplan show a significant reduction in the deposition of C3 in the kidney biopsy, and up to 71% of patients treated with Pegcetacoplan achieved zero intensity, so no deposition of C3 in the kidneys, which actually is again highlighting the effectiveness in terms of blocking the underlying pathogenesis. Importantly, the drug was very well tolerated. There were no significant adverse events. And importantly, there were no infections in the setting of encapsulated Neisseria meningitidis. There was only one death, but was unrelated to the drug, or was in the setting of a COVID pneumonia. And the drug was very well tolerated. And during the the latest ERA Congress, they also showed the results from the open-label phase, in which patients that initially were randomized placebo were switched to Pegcetacoplan. And as you can see, patients show a significant reduction in proteinuria, again, which at last follow-up achieved a minus 51%. And again, eGFR was trending towards stabilization. And with that, so the results, again, were very positive, particularly for the Pegcetacoplan, even though the Iptacopan was also positive. And now this is in this slide, I show sort of my personal view on how I would now treat, how the treatment landscape would look like now that we will have these drugs available. So in clinical practice, I will imagine a 4 profile of patients. So I imagine an initial profile of patients in which patients show sort of a mild clinical presentation with normal kidney function, proteinuria under 1 gram per day, no active lesions in the kidney biopsy. For this particular profile of patients, I would perhaps start with an initial conservative therapy with supportive care. However, I would do a close follow-up of these patients. And if I see a progressive increase in proteinuria, hematuria, despite this initial management, I would directly go for the complement target therapy. And the same occurs for this second and third profile of patients with would be those that have a more overt clinical presentation with proteinuria above 1 gram per day, or even nephrotic proteinuria above 3.5 gram per day, with active lesions in the kidney biopsy, with inflammation in the kidney biopsy, and no significant chronicity. For those, I would not start with immunosuppression and then escalate to complement target therapy. So if this complement target therapy has shown effectiveness in these clinical trials, I would not wait for immunosuppression. I would just go for this complement target therapy. And well, here I show Iptacopan or Pegcetacoplan, but perhaps Pegcetacoplan is more potent compared to Iptacopan. And I would just consider the use of concomitant immunosuppression as an add-on therapy to try to target inflammation within the kidneys, but just as a short course for patients that have a very aggressive form of the disease. And finally, for those that have more chronicity and no data on inflammation, perhaps I would just start with supportive care, and unless there are signs of progression together with proteinuria and microscopic hematuria or inflammation or active lesions, I would not consider as a first line the use of complement target therapies. And in terms of the way of monitoring these patients that are treated with target therapies, I would expect proteinuria reduction at least 30% at 6 months. Of course, if we are able to achieve a 50% earlier in the course of follow-up, that would be fantastic. And at least a 50% proteinuria reduction at 12 months, together with a stabilization of eGFR. In the mid to long-term follow-up, I would expect to achieve a proteinuria reduction of at least under 1 gram per day, and ideally under 0.5 gram per day, without significant microscopic hematuria and stabilization of eGFR. And for some profile of patients, perhaps it would be necessary to perform follow-up kidney biopsies to actually see what's going on in the kidneys and whether or not we are currently actually targeting the pathogenesis, and we are halting the inflammation within the kidneys. And so with that, I finish here with these conclusions. So as I have shown, this is a highly heterogeneous disease, so it is necessary to have a high index of suspicion, particularly when performing a kidney biopsy. Currently, it is associated with dismal outcomes in a significant number of patients. However, the results from these non-proximal complement inhibitors are really promising, and perhaps this will significantly change the natural history and the prognosis of the disease. As I have shown, Pegcetacoplan appears to be more potent compared to Iptacopan, and these show significant reductions in proteinuria, stabilization of kidney function, together with histologic improvements, and this was overall with a favorable safety and tolerability profile. However, there are still, as I show, important knowledge gaps that still remain, and of course, we will have to gather more experience with the use of these drugs, and we will have to have further studies to better analyze these particular knowledge gaps. And with that, I finish here, and I will be very happy to take questions.
So thank you very much, Dr. Fernando, for this elegant review of C3 mediated GN. We have many questions. I had to dismiss some of them because some have been already answered in the talk, and some may be a bit personalized towards patient care that might be hard to apply with minimal STEM. So the one question that people always ask is, why is it sometimes, despite being the same complement alternative pathway involved, why is it sometimes presenting atypical HUS and or C3 glomerulonephritis, and why does it get treated differently? So I think you touched a bit on that question, being the solid phase, being one type of the liquid fluid phase being more of a C3 mediated disease, and the solid phase in the endothelial cells being more of atypical HUS. What is the minimal workup required to diagnose primary immune complex MPGN and adequately exclude secondary causes?
Yeah, so perhaps I can start by answering the question. So regarding the differentiation between a typical HUS and C3G, actually, yeah, there is an underlying complement dysregulation, but it is still not well known why some patients develop solid phase predominant complement dysregulation, whereas in others there is like a fluid phase complement dysregulation. So perhaps there will be a combination of a genetic predisposition together with the importance of the triggering condition. Of course, it has been reported some very rare cases that have this concomitant C3G and microscopic TMA lesions also in the kidney biopsy. So this concomitant solid and fluid phase activation, but these are very rare. And the truth is that for atypical hemolytic uremic syndrome, anti-C5 therapies are the gold standard of treatment, whereas for C3G, we should target C3. And therefore, this is why eculizumab does not work effectively in C3 glomerulopathy.
Excellent.
And now regarding the diagnostic workup for MPGN, well, it is necessary to rule out chronic infections such as hepatitis B, C, whatever, and also other type of chronic infections, viral infections, and other autoimmune conditions. So we should do a differential diagnosis with other autoimmune diseases such as lupus, rheumatoid arthritis, or other systemic autoimmune conditions, and of course, other cancer as well. And it is also important to perform a comprehensive study to rule out monoclonal gammopathies, because patients may also show this membranoproliferative glomerulonephritis pattern, but there may be, there are these PGN-MID cases that may be misdiagnosed with MPGN or primary MPGN. And for such cases, I think it is important to perform a comprehensive differential diagnosis and a comprehensive histopathologic evaluation.
Excellent. So I have two questions that are kind of similar, and the question is, what is the prophylaxis that's needed typically when you're using agents like as Pegcetacoplan or Iptacopan? I'm not sure, how would you answer that question?
Yeah, so well, it is necessary to vaccinate patients for this encapsulated bacteria. However, we use concomitantly, we use antibiotic prophylaxis with, for instance, penicillin. There are no contraindications for that. We use a prophylactic dose concomitantly as a way of, improving the safety with the combination with the vaccination. Yeah, but it is necessary to vaccinate the patients before, and if there is this possibility, I think is better.
Excellent. Well, this is actually a good question, and I think it's a point of debate. Should a renal biopsy be performed in a patient with persistent hematuria and their proteinuria is less than 0.5 gram per day with stable GFR, let's say?
Yeah, this is a controversial point. So over time, I think we as nephrologists have lowered these thresholds of proteinuria. So some years ago, I would say, we tended to start with supportive care, trying to lower this proteinuria by using RAS blockade, SGLT2s, diuretics, whatever. But actually, we should take into account that by using supportive care, we are not targeting the proteinuria that comes from inflammation. We are just reducing the hemodynamics. We're controlling hemodynamics of the glomeruli. So this change, this paradigm shift has made nephrologists to lower this threshold of performing a kidney biopsy in order to early diagnose other underlying glomerular diseases that we will not be able to diagnose if we do not perform a kidney biopsy. Of course, if we perform a kidney biopsy, we will more frequently diagnose an IgA nephropathy, perhaps, compared to a C3G. But this way, we will be able to diagnose these rare cases of C3G that perhaps initially are misdiagnosed as a benign condition because of this initial mild clinical presentation. But having the diagnosis as early as possible, I think, is much better. So yeah, in our case, in our clinical experience, we have now reduced this threshold of performing kidney biopsy. And if we have a young patient with a proteinuria of 0.5, regardless of the use of supportive care, and particularly if the patient has microscopic hematuria, we perform a kidney biopsy and see what is going on in the kidneys. Yeah.
And actually, to add to that, recently now we're having emerging treatments targeting these pathways, whether it's IgA nephropathy or C3GN. So now it makes sense to do a kidney biopsy and start probably the treatment earlier than later. I think we're kind of reaching the end of the hour, so I would like to thank you again, Prof. Fernando, for this elegant talk. And I believe there are many people here are thanking you from the questions. And if there are any questions that we were unable to answer, I apologize. And I'll give the mic to Prof. Khalid Al-Hassan.
Thank you very much, Dr. Talal, and thanks to our eminent speakers that enlightened us with this complicated disease. Unfortunately, now there is target medication that it is available. Thanks for God's. Then those type of medication is available. Before we get stuck, we don't have anything to do with this thing. And the good thing is now it's already registered in Saudi FDA. Again, I would like also to thank all the attendees for their attendance and being with us and trusting the Saudi Society for Nephrology and Transplantation for its activity. So have a good night and see you next time. The only thing that I would like, before conclude, thank Sobi for their eminent supports and sponsoring this events, and thanks for them for continuous collaborations with your society. Last thing I would like to announce for our upcoming events, the glomerulonephritis conference that's going to happen in the mid of May in Riyadh at Crown Plaza Hotel, inshallah. Thank you very much, and have a great night.
Thank you.